All right, today we're going to talk about what we covered at the September EMS training. The big theme was trauma, MCIs, active shooter, regional response were sort of the main topics that we talked about. And something to keep in mind is that trauma is a load and go thing, very different than our cardiac arrest patients. This hasn't changed recently. This is what we've been doing for a long time, trying to have short scene times, getting IVs en route, getting to a trauma center. Those patients often need blood. They often need procedures, or if they're really bad, they need the operating room. So we don't have that on scene. So sticking around doesn't do any good. And we'll talk about that specifically when we talk about regional response here in a second. We'll talk about that more. We talk about hypoxia and hypotension. Both of those are very bad, particularly in head trauma patients with TBI. We see probably more hypoxia, I would say, with blunt trauma. So say you pull up a scene of an accident, somebody slumped over in the front seat, the windshield just started, and they're not breathing very well. They're probably hypoxic. That's a really bad thing because they probably have a TBI. Maybe they have some other major trauma. So correcting hypoxia is very important. Same thing, correcting hypotension is very important as well. So especially in head injury, correcting those two things is very important. It's important for all trauma patients, but more so in head injured patients. We also talked about permissive hypotension, right? So we just said hypotension we have to correct. How much do we correct it? A reasonable number to think is like a blood pressure of 90. A patient that's mentating okay and not passing out because their blood pressure is too low. Let's say they don't have head trauma. Maybe it's penetrating trauma. Keeping their blood pressure shooting for around 90, just keeping them enough to mentate. The idea about permissive hypotension is that if they have some internal bleeding that we can't control and we crank their blood pressure up to 160 because we're dumping in IV fluid, now maybe we're diluting their clotting factors and we're blowing off clots. So the idea is we can let them hover a little bit softer until we actually have control of the bleeding, which again is going to be in the ER or even the operating room. So again, that's probably not new. We've talked about these things in the past, I think. So we talked about IV fluid versus blood. We don't want to give more IV fluid that's just going to dilute the blood and dilute the clotting factors. It doesn't carry any oxygen. It doesn't have any clotting factors, right? So we talked about going to whole blood at Edina, which is something we're probably not going to do, at least not currently. Other systems have gone to carrying blood. Hennepin is carrying blood. Burnsville's carrying blood. It's a big opportunity cost for the number of trauma patients that we had that could benefit from that. It's an opportunity cost for the time, the training, the effort, everything that goes into that we're not spending on something else, which would benefit more people in the system as a whole. So as of right now, probably not going to blood or to be carrying any blood. Could we have a conversation with Hennepin because they're going to blood on their supervisor rigs? And again, this is a fall of 2025, so that could be a conversation that we have. So maybe we could meet them somewhere en route, I guess is my point. So more to follow on that. We talked about the lethal triad when it comes to trauma patients, and this isn't a huge part of what we do pre-hospital, but hypothermia, coagulopathy, and acidosis are the three parts of the lethal triad, and they all sort of feed off each other, and the patient gets worse and worse and worse. Once you have a big trauma of any kind, your body doesn't really maintain homeostasis very well, so you're going to get cold. Even on a hot day, your trauma patient might be getting cold. It's especially bad in the wintertime or when it's colder out. If you have a prolonged extrication in a car or something like that, patients are going to do really poorly when they start to get cold because your clotting factors don't work as well. Everything gets worse, and then when they get to the ER, OR, the ICU, all of these things just cycle and keep getting worse and worse and worse. A little side note on that, we were talking about the acidosis. We did mention briefly that giving calcium and bicarb and cardiac arrest and severe agitation are fine. You don't have to call for those orders anymore. Doesn't make a big difference in either one of those. That's debatable, right? In most cases, a reasonable approach in the ER is when a patient like DKA would be a more common time when we have severe acidosis for sure. Patients with a pH of around 7 often get some bicarb. It's a transient fix. It doesn't fix the underlying problem, but that's a reasonable time that people give bicarb, so like a pH of 7 or less. With these patients that are in cardiac arrest or with severe agitation, we don't know what their pH is pre-hospital. Obviously, we're not checking labs, but there's a little downside. The biggest downside in these cases is that you have to have a really good IV because that can be very necrotic if you blow out an IV with either bicarb. Calcium, glucose is also very toxic to the vessels, so you got to be careful about that. But if you have a good flowing IV in both these situations, I would give bicarb. Calcium also in cardiac arrest. But so as far as transport goes with the load and go idea here, just to mention this briefly, so there's some systems and some studies come out that saying that law enforcement transporting trauma patients have better outcomes. And that may be true, but in those systems there's also some confounders because often EMS is very delayed. So if you get shot in the street and a cop can throw you in a car in 5 minutes and take you to the trauma center and you're at the trauma center in 15 minutes, versus laying on the street for 20 minutes until an ambulance gets there. You're probably going to do better with no care in the back of a squad car at the trauma center, right? But again, there's some confounders there. So does that mean that we're never going to throw anybody in the back of a squad car, especially when we talk about MCIs? No, but with response systems in the metro in our area, we generally have decent response times that cops are probably in a routine day-to-day trauma of some kind that's not an MCI. We're probably not throwing people in the back of the squad car. So, all right, so let's talk about regional response. Again, this is a joint venture with the Hennepin County Fire Chiefs, Hennepin County Police Chiefs, that's been going on for quite a few years. It was revamped after the Uvalde school shooting. It's referred to as regional response, and it has to do with police activating the regional response and how many resources they get, how many fire trucks come, how much EMS gets deployed. There's layers to that we're not going to get way into the weeds on. It's also referred to as active shooter, which is the more common term. Granted, this could be anything. It could be somebody driving a car down a busy street, across a pedestrian mall. It could be a knife. It doesn't have to be a shooter. Any big MCI where there's somebody actively attacking people. So we break it into 5 phases. So phase 1 starts when the incident begins. So, and again, by the time this is all done, we hope to have all this done in like the first 15 minutes and have all the last wounded out, right, by the time we get to phase 4. And again, the idea being this is a load and go scenario. But the incident begins here whenever the attacker starts doing whatever they're going to do. People have to call 911. Depending on where you're calling from, your phone has to get routed to the right dispatch, because if you end up with state patrol, they got to route you to whatever city you're in. So there's layers to this delay. People have to recognize what's going on. They have to call. Dispatch has to be able to sort it out, get it to the right dispatch center, call the cops and get them coming, and then finally somebody arrives, right? So this time, there's a lot going on here that we have no control over. It's just the system until the first officer arrives. So we talk about that piece, but then the main training focuses on phases 2, 3, and 4. So the first officer arrives. Cops nowadays are taught to go in, even if they're by themselves, they're going to engage the threat. And the phase 2 ends when the threat's addressed. So whether that person surrenders, self-terminates, is addressed by law enforcement, gives up, gets shot, whatever that is, that's phase 2. Right from there, they have to make a big transition. So the vast majority of the time, only about 97 or 98% of the time, there's only one assailant with these incidents in the past. There's about 5 that have been multiple assailants. Obviously, Columbine is a big one that everybody remembers. San Bernardino, there was 2 assailants. But the vast majority of the time, it's only 1. So the law enforcement has to make a big shift here, because everybody's going to run in with guns. But once the threat is down, ideally with some of the first arriving officers, then we have to have some structure to make sense of dealing with things now. And law enforcement posture has to do a big switch from, we come in with the guns and we want, like, trying to track and hunt and kill the assailant and stop the killing. But now once that's done, again, only 2.5% chance that there's a second assailant. So we don't go to a zero security posture, but it is a big switch that it's not all about the guns anymore. It's about a framework and some sort of organization to this chaos to start working on getting wounded people out. So law enforcement has to make a really big shift at that point once the threat is addressed. So phase 3 starts when the threat's addressed, and now this is lots of organization here. So, and this ends when the corridor is secure. And the point is that those first arriving officers need to start organizing. They need to start they do set up security. So you sort of set a perimeter in sort of the hallway or the area that you can see. And this is not defined specifically. It's an area of the school, the building, the church, wherever it is. And then they need to have security. They're going to start addressing like audible bleeding, like people that actually have severe bleeding. They're going to start addressing that with tourniquets while they're also holding security. And then also going to be getting a wounded count so they can take command. Somebody inside is going to take command and call themselves interior and make sure that now they are the person that's organizing things inside and calling the shots and getting everybody organized with this framework. So once you have a wounded count and they're going to say the corridor is secure, they're going to have a casualty collection point. And again, I'm going over this very briefly, but that's the main points in phase 3. Once a corridor is secure, there's a casualty collection point. Now we're going to get all the wounded out. So in phase 4, this is when the rescue task forces come in, or RTFs. This used to be a big gaggle of lots of firefighters, lots of cops. We've trimmed that down. So basically it's 3 or 4 firefighters, typically with 1 cop holding security. They're going to come in, and again, that cop can help carry patients or is holding security. Again, we have a fairly secure area. It's not going to be completely secure, but it's going to be secure enough that people can come in and start getting wounded people out. And we're also ruthlessly focused on wounded people, which we'll talk about again here when we talk about like 10-second triage. Anybody that's got stuff to the head, neck, torso, and extremity, well, actually anybody wounded. In this case, it's anybody wounded. We're just getting them out. We're not sorting through a ton of stuff. We're not trying to do a bunch of triage on scene. Again, there's low chance of a second assailant, but IEDs have been used in these events. This scene is not secure in that regard, so we don't want to hunker down with people and start doing a bunch of stuff. We're not going to strip all their clothes off and start providing care, right? Because again, this is trauma, and trauma is load and go, like we already talked about. So the incident began here. We're minutes into this thing by the time we're down here getting these people out, so we're not going to do a lot of stuff here. We got tourniquets, chest seals, and we're getting people out. There's been discussion about, like, should we do finger thoracostomies or spears, like for chest wounds? And I've had conversation with Reed Smith, who's one that we'll come back and talk about him, and kind of an expert on this. There's not really much benefit to doing that. It's just going to delay things on scene. The other piece about this is that often, and the discussion at this last month centered around this, is that a lot of these agencies are going to be sending BLS firefighters. They're not paramedic level trained. Sometimes they're paid on call. They don't have a ton of reps, a ton of experience. So having those providers who don't have a ton of experience try to do triage on this stuff doesn't make a lot of sense. We just need to get people out. So again, tourniquets, chest seals, hauling people out. Phase 4 ends when the last wounded is out of that area. And again, this can scale so that it can be the west part of the school, the east part of the school, the north hallway, a second floor hallway, right? You could have different chunks of this same thing going on, or not chunks, different parts of the school may have the same process going on. Another very important thing that I didn't mention earlier is that this is a way to do this. This is not the way. There's other ways of organizing chaos like this. There's other trainings around the country, but this is a way to provide some framework so that we can work on getting people out, right? And we want everybody out in about 15 minutes. And then phase 5 is all of the aftermath, because it's a crime scene, right? The BCA has to investigate if an officer does some shooting to put the suspect down. Like, there's layers and layers of that. Reunification, people that aren't wounded, dealing with the dead. Like, there's layers and layers, and the class is not focused on that piece of it. So a couple of related points. The SALT, we don't use any specific triage model with regional response. Everybody's probably heard of SALT and START. None of those have been studied. They're all theoretical. The UK in the last few years has gone to 10-second triage, which basically, you can Google it. They have a whole PDF on it, but it works for any MCI. It's not meant to be just active shooter, but it can be used for that. And they basically, if you're walking, it's yes/no questions. Are you walking? Do you have severe bleeding? Are you talking? Are you breathing? That's about it. You're not having to count respirations. You're not counting pulses. Just walking, severe bleeding, talking, and breathing. So look that up for more information on that. And again, maybe some of that is happening when we get out here to the casualty collection point. We just want everybody out of the building as soon as possible to the CCP, where the ambulances are going to be pulling up. If they get triaged out there and you realize that you thought they were shot, but it's determined later that no, that really was just a graze wound on their torso and they're okay. And, we can make some decisions down the road, but we're not doing that in the scene, in the business, in the church, in the school. We're not making a ton of triage decisions right there. We want everybody who's wounded out. That's it. We're tactically indifferent to people that are not wounded, and we're tactically indifferent to dead people. Not that we don't respect them, but we can't do them any good. We don't need to spend time on them right now. So we just want the wounded people out as fast as possible. Again, for more reading on this, if you Google any articles by Reed Smith, he's an ER and EMS doc out on the East Coast. He's on a lot of the articles that talk about the wounding patterns in these things. We used to have military data. Now we have, unfortunately, more civilian data on this. There's one that looked at the Pulse nightclub shooting. If you want to dig into it, read some of the articles from him. As far as the MCI goes in terms of the hospital response, so a couple of things. HCMC has more depth. Essentially, they have a resident training program. So there's more ER doctors that are residents in training. So when those residents aren't on rotation during their essentially a 3-year FTO when you're a resident. When you're a surgery resident, it's a 5-year FTO program. So they have more providers in the hospital at any given time, right? You have the senior level people who are fully trained, and then you have all these residents of various levels on rotations in the hospital. So when they call an MCA in the hospital, they get a ton of resources to the ER, the ortho folks, trauma folks, the ortho trauma and the trauma folks. Maybe they're seeing people in clinic for their post-op, whatever, their post-op broken leg, their post-op gallbladder visit. But now they can come to the ER. They can clear the ORs very quickly. They can clear the ER very quickly. And so they have a lot of depth. We may adjust some trauma destinations in that regard. Like you normally don't send trauma to Southdale, depending on where this thing happens. But if it's a fairly minor trauma that doesn't need a level 1 trauma center, they can probably handle things that on a normal day they would maybe not handle, right? So some of that'll get adjusted, and that's not your call to make early on. At some point, MRCC is going to get involved and help try to adjust the flow of patients. But when in doubt, I'm going to say Hennepin has the most depth, the most availability. So I think that summarizes most of the points for September training. So hope you have a good fall, and we'll see you next month.